morning, everyone. Dr. Ng Edi, or better known as Jason, has been a medical lecturer and radiologist in the Biomedical Imaging Department, University Malaya, for almost 2 years. He obtained his medical degree in 2011 at Manipal University and his master in radiology in University Malaya in 2021. His true calling is interventional radiology. Many colleagues from referring teams would describe him as an easygoing, humble, friendly, and hardworking person. However, I think the adjective most would use would be accommodating and helpful. Thus, if you have any concerns regarding interventional radiology, please give Jason a ring. Dr. Jason has a special interest in lower GI tract imaging and frequently takes part in colorectal MDT in PPUM. This morning, he will speak to you about a topic that is becoming increasingly relevant in modern colorectal screening and diagnosis, CT colonography, also known as the virtual colonoscopy. As we continue to explore safer, faster, and more patient-friendly ways to detect colorectal diseases, CT colonography has emerged as a powerful tool in our current practice. Through this session, we hope to give you a clearer understanding of how CT colonography works, its benefits, limitations, and its role in the early detection of colorectal cancer, one of the preventable yet still prevalent cancers in our population. So, without further ado, the floor is yours, Dr. Jason.
Thank you, Dr. Prasath, for the kind introduction. Okay, I share my slide. Okay, so today I'm gonna go through a short presentation with you all about CT colonography, the current clinical application and some future development. So I'm Dr. Ng Edi, Jason from Biomedical Imaging Department. So a bit of introduction. In Malaysia, colorectal cancer is second most cancer in the general population. The incidence is about 11.1 and 14.8 in male and female and male per 100,000 population. And around 70% of these colorectal cancer patients in Malaysia were diagnosed in stage 3 and stage 4. So they came a bit late. And as you can see, in 2016, we did a follow-up by the Malaysia's board that we noticed that in stage 1 and stage 2 patient, the general 5-year survival actually is quite high, up to about 3/4 of them will survive up to 5 years, about 75-72%. But when they come in stage 3, the survival in 5 years left with 55%, and in stage 4, of course, about 70%, and even 1-year survival rate is in stage 4 is 55%. But the problem is most of them will still actually detect in stage 3 and 4, which reduce the overall survival of these patients. So a lot of screening protocol strategy actually is developed to try to counter this problem. Right. Sorry for the technical issue. So again, so most of our again, back to this slide, most of the colorectal cancer detection is at the late stage, stage 3 and stage 4, which reduce the overall survival. That we have a lot of strategy that we're trying to come through this problem. So the current screening strategy that Malaysia is adopting is an opportunistic based screening using immunochemical fecal occult blood test, IFOBT, that target asymptomatic individuals aged 50 to 75 years old group as a screening program. So the patient will go to a clinical center and then they will just enroll them randomly and then just give them this test kit, and then they will test whether any occult blood in the stool. If there is, then only they will bring them in either colonoscopy or CT. So this is a bit random screening program that we have now. Of course, symptomatic patient like having anemia or blood in stool is another group. That one is high risk group, or even have a strong family history, or they known to have a familiar colonic polyposis. That is another group. That group will need regular surveillance and also other set of screening protocol. So the currently the most done is, of course, colonoscopy is still the mainstay, and another thing is what we can want to go into CT colonography, or we can call it virtual colonoscopy or CT colonoscopy, or are all accepted terms for this scan. So CT colonography is a effective, safe, minimally invasive, and patient-friendly tool to detect carcinoma or any big colonic lesion like polyps or anything else. So this is how it looks like. It can reconstruct into a virtual colonography look that we can fly through the bowel wall in a digital way. And we can also see in 3 different planes in a CT axial, coronal, and sagittal to look for other things and also how the nature is. So it used the multiple thin slice computed tomographic data to construct these images. And the bowel mucosa will be seen in a 2 or 3 dimension nature. And it requires bowel prep similar to colonoscopy, but they don't require sedation because this is considered a rather painless procedure. So this is example of a case. This 58 years old male come with positive school of occult blood test, and during the CT colonography that we noticed there is a polyp at the colon, and this is how it looked like in the CT2 plane and A. This is a CT2 plane, and this is a virtual colonoscopy in a VR when volume rendering technique. We can see like real life kind of image that you can see this, and soon after patient undergo colonoscopy and notice there's a polyp there, okay, in transverse colon. So a bit on the sensitivity and specificity amount difference between these two mode of screening that the large analysis was done among these two studies, and they found that they have similar sensitivity to detect colorectal cancer and large polyp uh, if the lesion is more than 8 mm. Okay, so you can see in this graph, any lesion less than 7 mm, between 5 and 7, the sensitivity of CT colonography compared to colonoscopy is actually quite wide. It's up to about 10% difference. Specificity, of course, also lower. But if the lesion go up to 8 mm and above, 8 to 10 mm, the sensitivity actually comparable, 86.7% versus 88.5%. And the specificity also up to 90%. Of course, still not as great as colonoscopy because any lesion, polyp or any white-based polyp may look like colorectal cancer in CT, but at least we will be able to detect there is a lesion there for that patient. And any lesion more than 1 cm, 10 mm, the sensitivity also very comparable with colonoscopy, 91.2% versus 92.9%, about 1 to 2% difference. And again, specificity is of course still lower because CT is after all still imaging. Patient will may still need a colonoscopy later. Okay, so but CT colonography got a few additional value uh, in comparison. So it can accurately assess where the lesion and location, the lesion location and how it extends. So for example, and this patient on your left, there is a mass in the descending colon, and you can see a lumina is very narrow, and usually the scope will not able to pass through this kind of narrowing. But the patient actually have another lesion at this hepatic fracture or the ascending colon here that um, can be seen in the CT colonography that we can actually assess if there's any synchronous tumor. And of course, we also can stage the patient, and if the patient have a tumor here in the descending colon here, and you can see this patient also have a multiple liver metastasis. So actually we can know better how the disease extension, a bit of abdominal staging, how the node was involved. Um, and also even some extraluminal mass may not be able to see in a conventional colonoscopy. The mass may come from the wall and just a bit abutting into the lumen that is better visualized in CT in those cases. So but currently we still put up some indication for CT colonography overall because to guide the patient when the patient should be referred for CT colonography. The first stuff, of course, is a field colonoscopy that the patient may have a stricture, mass, or redundant lobe. We call it dolicho colon, like this image on your left. As the scope go in, sometimes they have a very acute angle or very redundant, extra long sigmoid colon. This is actually very common if as we have reported a lot of CTs and stuff, sigmoid dolichocolon or hepatic fracture, spring fracture dolichocolon actually is quite common that can be very challenging to scope in certain patients. Then of course, patient may refuse for scope because it can be quite uncomfortable. And some patient may be afraid of pain. So that's why sometimes we give sedation during the scope. And of course, a frail and very old patient, like big bowel patient, very old, 80 and above. So there's a study stated that this group of patients have a very increased risk of bleeding and perforation. And of course, another contraindication also relatively is patient have a bleeding dysplasia. They say the patient have some bleeding disorder that easily bleed, then can consider to do CT colonography first. Actually, they are not replaceable each other, but in certain patient, like very old patient, but they say they have some symptom, anemia, a bit of auto bowel habit, we actually can offer CT colonography to detect if there's a lesion first. Then, if there's a lesion there, then we can further convince the patient to do a scope for HP and things like that. So it's actually adjunct each other. Actually. So this is another example that this patient has a very acute angle of the sigmoid colon here on your left image A that uh, is very technically challenged to scope and go through this angle and go, but the patient actually has symptom. So CT colonography was done, and you can see there's a in this VRT image, volume rendering technique image, you see the asterisk part, there is some filling defect, some narrowing at that region. And then when we see back the 2D view, the coronal view, we can see there's a polyp coming from the inner wall at the descending colon here. That then we know this patient have a lesion there. That even scope cannot go through, then we can either follow up with CT or can offer some form of treatment. But of course, it comes with some disadvantage. So sometimes if the bowel is not properly prepared, there will be fecal material, like this image on lower here. So this feces adhering to the bowel wall, as you can see here, it did look like some lesion for us radiologists. We say, hey, maybe there's some wall thickening there. And then even in the virtual image, it looked like very irregular wall. That's one of the pitfall of imaging, that if the image looks like a lesion in this kind of case. And of course, it can be false negative, especially in very small lesion, as we just go through just now. If the patient have a less than 8 mm lesion, the chance of missing is up to 20% plus. So unable to give HP example. We can only tell there is a lesion, but we cannot tell is it a benign, is it a malignant lesion. That one imaging cannot tell. And of course, it's coming with some radiation. And another thing to be looked into is contrast-related complication. And there's a small chance of bowel perforation in these kind of cases because we inflate the bowel, distend it. Okay, so this need to be bear in mind, but the overall is still lower than conventional colonoscopy. So few contraindication we need to keep in mind is if the patient got ongoing active bowel infection or inflammation, say during active diverticulitis or active IBD, ongoing infection, then we will try to postpone the appointment because of the inflation may cause some perforation, higher risk of perforation. Pregnancy, of course, no, because radiation. And any recent abdomen pelvic surgery, even a large lesion biopsy, we try to postpone because it again risk of perforation. Okay. Okay, a bit on bowel preparation. So this patient need to be prepared for CT colon, quite different from our conventional CT. So patient need to undergo low residual diet and bowel prep prior to scan, and also during the scan need to be the bowel need to be inflated. This one need to be highlighted because it's not uncommon. We have a request patient came with all the indications of fecal occult blood positive, or they have even altered bowel habit, but they actually came for a CECT abdomen pelvic scan. This is a thing that I also would like to highlight here, that the requesting team, and also when you refer the case, we need to note it actually is a different there's a different protocol, and we need to prepare the bowel and also need to inflate the bowel for this CT colonography patient. Although the image come out will look quite similar, but the interpretation is different. If the patient didn't undergo bowel prep, or we didn't go through this CT colonography protocol, the detection rate and the sensitivity will much reduced. Okay, so how we prepare in our center is we give low residual, we advise low residual diet for 2 days, basically reduce vegetable, reduce fruit, avoid, totally avoid. Then just also avoid any milky product. Basically, I will ask the patient usually to take clear fluid as in any fluid they can see through, like tea, coffee without milk, and water. Then we give Ducolex 2 and 3 days before the scan, like you can see in this form here. We actually have this is our form in our center. So as we can see, we will ask the patient to take we will write the date for them, take Ducolex. Then from day 2 before, we will ask them to have low restricted diet and also take Ducolex again. We used to ask them to give take some oral contrast for fecal tagging, but we no longer do that. There's some pros and cons of that, but um, I will tell you all later if we have time. Then the most important one will be this day 3, the Fortran preparation. This is bowel prep, I think similar to colonoscope. The night before, we prescribe 2 sachets of Fortran in 2 liters of water, separate those, and ask the patient to drink overnight. Then they will purge. So again, low residual diet, and this usually will give a very good bowel preparation for the patient. This protocol. So this is what patients should know. So before that, they will need to have clear fluid. They need to take the Ducolex, and also they need to have a bowel prep. In this image, they say drink contrast, but we no longer practice that in our center currently. So on the day, the patient we will insert rectal tube and inflate gas until patient feel a bit uncomfortable. Then we will stop. Okay, then we will do the CT scan. Okay, the whole process usually take about 15 minutes to 20 minutes. That's all. Okay. And this is our scan protocol that we adopt in our center. We will put the patient in a prone position and perform a plain CT, and then we put them supine and perform a CCT. This is one key different that different from our conventional CCT abdomen pelvis, because the bowel may have some fluid, and the dependent region may be obscured by the fluid. So by doing this 2 position, we actually eliminate that problem. And that's why, and also since we inflate the bowel, you can see the image here on the left lower corner. You can see the bowel is well distended, and we can actually do a CT virtual colonoscopy, or we can even see the imaging. You can see the wall very clearly. Compared to the normal CCT abdomen, we actually don't really bowel prep, and we don't inflate the bowel, and we will not able to see a very small bowel lesion in those kind of case. So we can also do a virtual cut through of the whole bowel, and we can see if there's any lesion. We can examine the wall in a cross sectional cut open method manner. So okay, this is how the virtual image look like. Of course, we usually like to see a three-plane, this conventional image like B and C, the axial reconstructed image. So this is how it will look like if this patient have a colon tumor. As you can see, this is quite a huge tumor, but in CT it may look like just at the wall. And if you don't bowel prep this patient, this may not be detected because the bowel may be collapsed. Then the other one will stick onto this lesion, and we may miss it. So this is the normal exit image. That this is the VRT image that we can do this green line is where we do a virtual fly through colonoscopy to see the wall. And this is the image. And if we stop at that lesion region, this is how it look like in the virtual colonoscopy. And of course, the patient later undergo colonoscopy, and this will be the actual image. So this is just to give you an overview how it looked like in a different modality. In a CT cross-sectional image, it looks actually quite small, looks like it, but in real life, it can be quite a huge lesion there. And this is in a virtual how it look like. Okay. So a bit on the 5-year projection of where we are going to in for CT colonography is still not many cases at this point of time, and we don't use fecal tagging because some article suggest that fecal tagging technique basically we just ask patient to drink contrast the night before, and then all the residual feces material will be tagged, that's kind of tagged by this contrast, and then we can do all the contrast tag feces, and we can have a better view. But some studies has shown that it may obscure some lesion beneath all these residual fecal material. So bowel prep is that's why in our center we still prefer bowel preparation. But certain newer technique of fecal tagging and electronic subtraction suggest that they have a very high sensitivity that reduce the error rate. So in the future, maybe we can look into a laxative-free examination that should be more comfortable, because most patients have undergone bowel prep with diarrhea. Actually, it's a very uncomfortable thing to go through. They purge all night for multiple times. That some patients may be even a bit reluctant after that. So this is something we can look into, but we haven't practiced that. And then another thing is low radiation protocol. We already have a quite low radiation protocol in our center, but in certain study they're even looking into even lower, because we are trying to worldwide they're trying to expand this examination into a mass screening program. Then you need a very low radiation protocol to to protect the patient, to reduce the risk of the radiation. So if we have a next generation reconstructed image program, iterative algorithm, actually basically mean how we reconstruct the image. If we have a newer generation program and things, we maybe can further reduce the radiation dose for patient. And another thing, of course, the current big thing is AI. Whether in the future we can incorporate AI into this reading and increase the diagnostic accuracy and efficiency, if this go into mass screening program, because it actually take time to go through one CT colonography. You can see in 3 plane. We have to do the virtual colonography. It actually takes time, and actually take some time to train radiology trainee to see this kind of image that have a good detection rate. Whether AI, I think in the future AI will help in this kind of work. Maybe they can at least tell, these are the region of you should spend a bit more time, and we can see that region. So this is the few thing. Another thing is can CT colonography be used as a screening test in the general population? Is CDC has mentioned this as a potential use of screening tool for every 5 years. Some country has set a protocol for certain risk patient. They suggest to do every 3 to 5 years, depend on patient risk and depend on the local practice. But because in a medical economic standpoint, CT colonography every 10 years should be less expensive and more effective than the stool or cord blood every 2 years. And the detection rate of stool or cord blood is, I think, 0.33%. To get some abnormal result, but CT colonography, it will be up to 0.5%. So it's about 15-60% raise detection rate overall for asymptomatic patient. So and power in this point of time is not feasible in our center or in our country for the next 5 to 10 years, probably for to be used as a mass screening program for asymptomatic patient, because we are lacking machine. As you know, the CT waiting list can be very long in most center in basically all center of radiology Malaysia. And we also don't have that much manpower and expertise to read this. So if we have to incorporate this in as a screening program, of course the acceptance rate will be slightly lower, which actually cancel the usefulness of screening. That's why in this very moment we still don't do this as a mass screening program. We only that's why we still have an indication that have as a guide for clinicians to decide which patient they should send for CT colonography. So few key point bring home message for today's talk. CT colonography is a reliably screening tool for colorectal cancer or mass, especially more than 8 mm. Okay, so with comparable sensitivity and specificity with colonoscopy, and however they are not interchangeable. It's not like the patient have done CT colonography that they can avoid CT colonoscopy. You have to tell the patient, we can detect something, but after that you may still need to undergo CT colonoscopy. It's not replaceable each other, but it can adjunct each other in a lot of clinical scenario. So it's a useful tool to detect coronary lesion for patients that are unable to complete or undergo colonoscopy. Okay, and there is a potential false positive or false negative rate in CT colonography. This need to be known. Patient need to be aware. If the CT colonography is negative, doesn't mean that 100% you don't have problem. Especially if you got symptom, he got school or couplet persistent, he got outer bowel habit, very high risk. Sometimes we should still consider to repeat in some interval like 1 year, 2 year, depending on the patient risk. So this really need to told that and also if the CT colonography is positive, sometimes actually it's just a fecal material or things. This need to be counseled to the patient before we start the scan. Because patient will have a idea that, oh, I have done this scan, it's negative, I think I'm normal. No, that have to be told to the patient before the scan actually. Okay, I think there ends my this is my reference for today's talk. Thank you.
Thank you, Dr. Jason, for your talk. I think it's been very insightful to our audience. Hopefully, we will be able to offer more patients CT colonography and help them out. Okay, we have a question here. from Prof. YK Chen. She asked, what is the uptake of this new technique by the global population as well as in Malaysia itself? So how popular or prevalent is CT colonography in Malaysia and worldwide?
Thank you, Prof, for the question. From what I read up, in the Western, of course, the acceptance rate in the Western country is more widely used now. Some patients even undergo a very regular screening 2 yearly for CT colonography. But in Malaysia, from the field, we don't have a study and a very exact number I can't tell you. But from my experience in field center in this country, the rate of requests and even the acceptance rate is actually still considered low. I actually even helped to set up this CT colonography actually not long ago in one of the hospital in Sabah, just about 3 to 4 years ago. And we are just starting to offer CT colonography at that center at that point of time. So you can see we are actually relatively new in this field. But actually UM has offered this scan for many, many years. We have started quite long. But the request or the frequency of doing this scan actually is not that frequent yet. And also, I personally noticed that there's quite a number of patients actually indicated for CT colonography, but the request is CCD abdomen. I think that's why I decided to bring up this topic and raise this awareness to all the everyone who attended this talk, that actually there's a key difference in CCD abdomen and CT colonography. The preparation, the scan protocol, everything is different. It leads to a much higher detection rate in CT colonography. I hope that answers your question. Yeah.
Thank you, Jason. There's a follow-up question here from Prof. YK Chen. So I'm not sure, but I'm just going to ask if Jason is unable to answer, maybe later he can type it in the Q&A box. So she asks, how extensive is fecal blood detection in our hospital or country? And who would send their patients for detection? Is it doctor initiated or patient initiated?
Thanks, Prof, for the question. I hope I can answer it correctly because I asked I asked my friend who work in clinic kesihatan in one of the center in Rawang, in this state, about this. According to her, that is doctor initiated, and they will recruit the patient. There's no. I hope I'm not wrong, but if there's any surgical colleague here, maybe they can give us a better idea. But according to the national protocol, the screening program for the current guideline by KKM, that they are, of course, they are high risk group. There are lists of risks that like the smoker, high family risk, and familiar polyposis and things. But from what I noticed, I asked from my primary care friend that they basically take the patient a bit quite randomly. But of course, if the patient is a smoker, no symptom, they will kind of advise them and offer them whether they want to go through this IOPT. That's what I find out from my friend recently due to this talk. But whether this in a Malaysia-wide scale, I can't tell. Maybe if there's any Ruka expert here or surgical colleague can chip in idea. Yeah, thanks.
Thanks, Jason. So yeah, if there are any other experts who would like to chime in, yeah, please do in the chat box to help Prof. YK Chen. Okay, so I think that's all the time we have for the first half of our breakfast lecture. So I'll pass the baton off to Dr. Jay Ganesh and Dr. Mohammad Fitri. Thanks.